Chapter 21, we are talking about the cardiovascular system, and Chapter 21 is packed full of your review of normal anatomy and physiology. Then it goes into your assessment, basically, of that cardiovascular system. Then we move in towards our diagnostic test and our therapeutic intervention. So again, this chapter is going to be divided into two different parts so that we can grasp those concepts. So looking at part one, we are definitely going to focus on the recap of your anatomy and physiology. You've gotten handouts or have been sent handouts that kind of coincide with this lecture. So as I tell you to reference those handouts, please pull them out. Please look at them as we go over them throughout the course of the slides. With your cardiovascular system, your components of the cardiovascular system include your heart. That is going to be one of the major organs associated with your cardiovascular system. Now, in addition to that major organ of the heart, we're also going to be evaluating and looking at blood vessels, your blood vessels being the three different kinds, your arteries, your capillaries, and your veins. All of these structures make up and constitute your cardiovascular system. Your heart. The heart is located in the mediastinum of the thoracic cavity, and on your slide as well as in your text is this picture that shows you the anterior view of the heart and the major blood vessels. This is about a fist-size shaped organ that is sitting in that mediastinum of the thoracic cavity. So it's not very big, but it's of great importance. It is nourished by several coronary arteries, and you can see those outlined in this picture. And you can see blue as well as red types of vessels. Those colors are to represent oxygenated versus deoxygenated blood. And as we talk about circulation, blood flow through the heart, the different circuits of circulation, we're going to reference oxygenated blood versus deoxygenated blood. Your heart is enclosed by three membranes, and those three membranes make up basically what is referred to as your pericardial sac. And the three membranes include fibrous pericardium, which is the outermost membrane. It forms that loose fitting pericardial sac around the heart. You have the parietal pericardium, which is the second or middle layer. That is a serous membrane that lines the fibrous layer, and a visceral pericardium, which is the third or innermost layer, that is also a serous membrane that lies directly on the surface of the heart. Now, between these two middle layers, the second and the third, your parietal pericardium, your visceral pericardium, remember they're both serous membranes, so there is a serous fluid that is contained between those membranes that helps prevent friction as the heart pumps and as it contracts and those different membranes rub against each other. Your cardiac structure, in addition to the pericardium, which basically surrounds the outside of the heart, we have what is called your myocardium, as well as your endocardium. Your myocardium is the cardiac muscle itself that creates the walls of the four chambers of the heart and the septum that separates those four chambers. Your smooth epithelial tissue, called endocardium, lines the four chambers, covers the valves, and continues into your blood vessels. This smooth epithelial tissue, called the endocardium, is on the inside of the heart. So the pericardium is the outside. Think about the pericardial sac that surrounds the heart. Your myocardium is the actual heart muscle that does a lot of the contracting. And then your endocardium is the inside of the heart, the layer that lines your different chambers. Your coronary vessels are very, very important when it talks about healthiness of your heart and that myocardium. With your coronary vessels, they help provide coronary circulation, and that's oxygenated blood that is carried throughout the myocardium and helps to return deoxygenated blood to the right atrium. There are two major coronary arteries, and they are the first branches of that ascending aorta that comes just off of your left ventricle. So when blood pumps out of your left ventricle, it is going to enter the aorta, and the aorta is the huge artery that takes blood out to the body. But just off of that aorta, as it is extending upward towards the aortic arch, there are going to be two primary branches of coronary arteries, and you can see that outlined in the picture in your slide. There is the left coronary artery that nourishes the left side of the heart and kind of wraps around towards the left back side of the heart. Then you have the right coronary artery that nourishes the right side of the heart and again encircles the posterior side on the right. So those two main branches of coronary arteries are going to be responsible for diverting a certain percentage of blood from that aorta that is supposed to be going out to the body. A certain percentage of that blood is going to be directed to the myocardium itself. The myocardium is a muscle. It does require oxygenation, so there has to be some perfusion, some circulation, some nourishment to that myocardium for it to be able to keep up and keep the heart pumping as it should. Now, this left coronary artery, this right coronary artery will have separate little branches on them that will be named according to the coronary arteries. We'll talk a little bit more about that later on in this particular unit whenever we talk about myocardial infarctions, because myocardial infarction is a heart attack, and that is where these coronary arteries are blocked and they are not getting or providing oxygenation and nourishment to that part of the myocardium. And depending on which coronary artery is affected will depend on where that heart attack occurs, because remember, there's lots of little branches coming off that are going to nourish certain areas of this heart muscle called the myocardium. Your heart chambers, there are superior chambers and there are lower chambers. Your superior chambers are referred to as the atria. They are usually thin-walled, and you have a right atria and a left atria. They are separated by the intra-atrial septum, so that's kind of like the divisional line. Your lower chambers are thicker walled. They are referred to as the ventricles, and you have a right and a left ventricle. They are separated by an intraventricular septum. Now you have a picture of the heart on your slide, and you can see how they divide it into upper and lower as well as left and right. So you have a right atrium, which is an upper chamber, a right ventricle, which is the lower chamber, with a thicker muscle. Ventricles always have that thicker portion of the muscle. That's why they're thicker walled. On the left side, you have a left atrium and a left ventricle. And again, your left atrium is the upper, the ventricle is the lower, and the left ventricle has the thickest of all of the walls because it has to pump a little harder. Its workload is a little more demanding, and we'll talk about that in just a few minutes. With your coronary blood flow, you have deoxygenated blood, which is coming from your coronary arteries, also coming from the body via the superior and inferior vena cava. That blood enters into the heart from those vena cavas into the heart via those vena cavas into the right atrium. That's where everything gets started. So blood is returning to the heart via the vena cava, superior and inferior vena cava, into the right atrium. From the right atrium, it will flow through the tricuspid valve. From the tricuspid valve, it flows into the right ventricle. From the right ventricle, ventricles always push blood away from the heart. So it is flowing through a pulmonary semilunar valve into the pulmonary artery. Okay, arteries always carry blood away from the heart. So we're going or leaving the right ventricle, going through the pulmonary valve into the pulmonary artery to travel to the lungs. It is at the site of the lungs, specifically the lung capillaries, that oxygen and carbon dioxide are exchanged, and this blood now becomes good oxygenated blood that returns to the heart via the pulmonary veins into the left atrium, through the mitral valve, to the left ventricle, out the aortic semilunar valve into the aorta to go to the coronary arteries and to the rest of the body. Now, y'all, you need to know this blood flow through the heart. I've got a worksheet that I have given you that you need. It's like, kind of like a fill in the blank kind of thing to help you kind of remember, okay, what is the steps in terms of this blood flow through the heart? You need to know it. Okay, let's recap it just a little bit. You have deoxygenated blood that's been used up by the body. Deoxygenated blood, it comes into the heart via the superior and inferior vena cava. So we got body, superior, inferior vena cava into the right atrium. This is the first chamber blood enters into from the body, is the right atrium. From the right atrium, it passes through the tricuspid valve. Right. So that's the valve that's on the right side of the heart, the tricuspid valve. From the tricuspid valve, blood flows into the right ventricle. Leaving the right ventricle, we pass through the pulmonic valve, pulmonic because we're headed to the lungs. We pass through the pulmonic valve into the pulmonary artery, artery because arteries take blood away from the heart. That pulmonary artery takes this blood to the lungs where carbon dioxide is exchanged for oxygen. Oxygenated blood now enters the pulmonary veins. Veins always carry blood to your heart. Pulmonary veins carry that blood to the left atrium to pass through the mitral valve, which is the bicuspid, that's another name, into the left ventricle, through the aortic valve, into the aorta, to the coronary arteries, into the body. Okay, so you need to know your sequence of blood flow through the heart. You may even be asked to write that out step by step, and if you miss a step, then you get it completely wrong. All right, so deoxygenated blood to the heart via the superior inferior vena cava into the right atrium, through the tricuspid valve into the right ventricle, through the pulmonic valve into the pulmonary arteries, to the lungs where oxygen and carbon dioxide are exchanged, now into the pulmonary veins, to the left atrium, through the mitral or bicuspid valve, into the left ventricle, through the aortic valve, into the aorta, and then out systemically, coronary arteries into the body. Please review that. Please learn that. That is a very key step whenever we start talking about the valvular disorders and heart failure. You will begin to see that there is a backing up process, and you need to know what the normal blood flow through that heart is in order to understand where is the blood backing up. What will I see in terms of signs and symptoms related to where this blood is backing up. So you've got to know what's the normal sequence or normal pathway for this blood to come from the body, circulate through the heart, and go back out to the body. You've got to know the normal blood flow through the heart so that when we address the disorders that interferes with this normal flow, you can retrace it backwards. Valves. Your heart does contain 4 valves that are very important in terms of keeping blood flow going in the right direction. Your valves help to prevent a backflow. They allow blood to move forward, they close off so that there is no regurgitation. When you see some regurgitation, that indicates that there is some valvular problems that can contribute to other heart diseases and disorders. You have the tricuspid, right. So this is the valve on the right hand side of the heart. It's considered an atrioventricular valve because it is between your right atrium and your right ventricle. So the purpose of this tricuspid valve is to open up and allow blood to flow from the right atrium into the right ventricle. And as it gets into the right ventricle, the forces build up and close that tricuspid valve to prevent backflow, because when that ventricle contracts, you don't want it to push blood backwards into the right atrium. You want it to go forward into your pulmonary artery. So the tricuspid helps to prevent backflow from the right atria during ventricular systole meaning contraction. Your pulmonary valve is the next valve on that right hand side. Pulmonary valve is considered to be a semilunar valve. It prevents backflow of blood from the pulmonary artery into the right ventricle. Your mitral or bicuspid valve, or now on the left-hand side of the heart, prevents backflow into the left atrium during ventricular systole. So your mitral and your tricuspid are considered to be the atrioventricular valves. These are the two valves that sit between the atria and the ventricle. Tricuspid's on the right, mitral or bicuspid's on the left. Your fourth valve is the aortic valve that prevents backflow into the right ventricle from the aorta during ventricular diastole or relaxation. So two new terms here you've heard me using. Systole means contraction. This is where there is emptying of the chamber. Diastole is relaxation. That is where the blood is filling up the chamber. These valves have cusp. Your tricuspid valve, tri means three, so it has three cusp. Your bicuspid or mitral valve has two cusp. And these cusps are made of connective tissues that are covered by endocardium. Remember, endocardium is the membrane or the structure that is on the inside of the heart that lines our chambers and our valves. Your valves are anchored to the floor of the ventricles by finger-like substances. You can see those pictured in your slide. The little figure to the left hand, you see that white stringiness where you see the line pointing to aortic and mitral. You see that there are white little spider webs type strings coming from the bottom. That is what is referred to as chordae tendineae, and they are anchored to that papillary muscle of the ventricular floor. Each ventricle pumps the same amount of blood. Doesn't matter if it's on the left or on the right, each ventricle pumps the same amount of blood. But there is a difference in the force of contraction between the left ventricle and the right ventricle. Your left ventricle is thicker and it pumps 5 times more forcefully than your right ventricle. Your left ventricle has to overcome the greater pressure of systemic circulation. In other words, when your left ventricle contracts, and the word for contracts is systole, when there is left ventricular systole, that left ventricle has to shove blood out through the entire body. So it has to overcome systemic pressures throughout the body. Versus your right ventricle, from your right ventricle, blood is going to the lungs. And yes, there are some pressures in the lungs that helps keep the natural process of breathing going, that helps to create that exchange of gases at the capillary bed. But those pulmonary pressures are nothing like the pressures throughout the entire body. So your right ventricle doesn't have to work as hard to push blood into the lungs. Those pressures are smaller. So although the right ventricle wall will be thicker than your atrial walls, the right ventricle wall still will not be as thick as your left ventricle. Your left ventricle is considered to be that workhorse of the heart because it helps to provide oxygenated blood to the entire body. All right, so although each ventricle, left or right, pumps the same amount, the left ventricle pumps 5 times more forcefully than the right. Your cardiac conduction system, you will see on this slide how they are outlined. And again, you need to know this sequence. I've got a couple of slides that's going to follow where I can show you kind of the location of these different entities that are part of this cardiac conduction cycle and this cardiac conduction sequence. But first, to review it, cardiac conduction starts in the SA node, which is called the sinoatrial node. Flows, that electrical current then flows from the SA node to the atrioventricular or AV node, from the AV node to the bundle of His, from the bundle of His to the right and left bundle branches down to the Purkinje fibers. So that is the sequence that you need to remember. SA node to the AV node to the bundle of His, to the right and left bundle branches to the Purkinje fibers. Okay, now let's change slides and kind of look at where they are in terms of anatomy. This is the picture that is contained in your text in figure 21.3, and all of these little boxes give you some information about the various structures of this cardiac conduction pathway. This pathway is where electrical impulses generate a heartbeat, and there is a specific sequence that we just went through on the previous slide. You have the SA node. SA node is situated in the upper right atrium of the heart. It fires an impulse at 60 to 100 beats per minute. Now from your SA node, the electrical impulse will travel to the atrioventricular node, the AV node. Now that should tell you that this is situated kind of right between the atria and the ventricle. And your AV node fires electrical impulses at a little bit slower rate, being 40 to 60 beats per minute. Your AV node is considered to be kind of like the gatekeeper. It decides if the signals from the SA node are going to go forward down into the ventricle. Because remember the name of this little entity, it is the atrioventricular node. So it is the node that sits at the bottom of the atria, at the top of the ventricles, and it decides whether this signal passes on down to the ventricles. So it's the gatekeeper, the bouncer is what I like to call them. From the AV node, your signal flows into the bundle of His. The bundle of His can fire a current at 20 to 35 beats per minute, and this is the beginning of where the impulse is traveling to the ventricles. It has been approved to get through the AV node. The bundle of His starts that ventricular electrical process. From the bundle of His, the electrical signal passes through the right and left bundle branches, so it travels down. And if you look at your picture, those red areas, that's the left and right bundle branches, and they are traveling down your septum. Your septum is that intraventricular septum that divides the left from the right. And then from the bundle branches, we travel into the Purkinje fibers, which are that turquoise kind of blue, that bright blue there on the bottom. Purkinje fibers are what is going to stimulate the muscle of the ventricles. And you have Purkinje fibers on the left as well as the right, but you just need to remember Purkinje fibers. Okay, so again, you have the little blocks to give you some information about the various structures, but the sequence is SA node, impulse originates, or normally, the normal anatomical anatomy and physiology should be this electrical stimulus originates in the SA node. It travels to the AV node, which sits between the atria and the ventricles. It's the bouncer, deciding where their signals go forward, to the bundle of His, from the bundle of His to the right and left bundle branches, down to the Purkinje fibers where ventricular contraction occurs. Let me also make reference. Your SA node is situated at the upper portions of your right atrium. However, we have said, or we should understand, that both of your atria are going to contract at the same time, and then both of your ventricles are going to contract at the same time at just a split second behind your atrium or atria. So that SA node, although it's situated in the right atrium, there is a connecting pathway so that your left atrium can be stimulated as well. So SA node is responsible for kind of stimulating your atria to contract. The signal then travels to the AV node, where your AV node decides, okay, does this need to pass on to the ventricles? If so, that AV node sends the signal to the bundle of His. From the bundle of His, the signal travels down the right and left bundle branches to the Purkinje fibers, which will cause your left and right ventricle to contract simultaneously. And again, in your picture on the slide, as well as figure 21.3, the structures are kind of color-coded so that you can see how they flow through the heart. The upper portions are the atria, the lower portions are considered the ventricle, and they are divided by a septal wall. All right, and that's the bundle of His, as well as your left and right bundle branches flow through that septal wall. And this is the final slide that again kind of outlines the structure of your cardiac conduction pathway. SA node to the AV node to the bundle of His, down the left and right bundle branches to the Purkinje fibers to cause those ventricles to contract. Now, when we talk about electrical conduction, that is responsible for maintaining a cardiac cycle. And a cardiac cycle is the sequence of mechanical events during one heartbeat. So the electricity stimulates the muscle to have some mechanical events. And these mechanical events include two atria contracting simultaneously, followed by simultaneous contraction of the two ventricles. We review your terminology. Systole means contraction, and when it contracts, it is emptying out that chamber of blood. Followed by diastole, or relaxation, where blood is now filling up that chamber. The events of the cardiac cycle create your normal heart sounds. Lub is the first sound, and that lub is caused by closure of your atrioventricular valves during ventricular systole. Atrioventricular valves are closing with that lub sound, and your atrioventricular valves are that tricuspid valve and the bicuspid or mitral valve. Dub is the second sound, and it is caused by closure of your semilunar valves, and that will be your pulmonic valve and your aortic valve. All right, so your cardiac cycle is the sequence of mechanical events that gives you one heartbeat. So your atria contract together, then a split second later, your two ventricles contract together, and we are looking at sounds such as lub-dub, 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 lub-dub. The lub is the first thing you should hear, and it means your tricuspid and your mitral valves are closing, and they should close at the same time because your two ventricles are going to contract at the same time. And just before those ventricles contract, pressure builds up in those ventricles because blood is filling up that chamber and slams shut those valves. That's your lub. Dub is caused by closure of your pulmonic and aortic valves so that blood doesn't backflow from the pulmonary artery or from the aorta back into the ventricles from whence they came. So normal heart sounds, lub-dub, lub-dub. Lub is the first sound and caused by your tricuspid and mitral valves closing. Your dub is the second sound, and it's caused by your pulmonic and aortic valve closing. Cardiac output is the amount of blood ejected from the left ventricle in 1 minute, and there is a formula to help us determine what that number is. We use stroke volume multiplied by heart rate. Now, Miss Oakley, what in the world is a stroke volume? Well, that is the amount of blood ejected by the ventricle with 1 heartbeat, and we're looking at anywhere from 60 to 80 milliliters per heartbeat coming from that ventricle. Your heart rate obviously is how fast the heart is beating, and the average resting rate is around 75 beats per minute. So if your formula is stroke volume times heart rate gives me cardiac output. So we would use stroke volume, the amount of blood ejected by the ventricle in 1 beat, 60 milliliters per beat, times your heart rate, 75 beats per minute. You are looking at an output of 4,500 milliliters per minute, or about 4.5 liters per minute. Now, 75 is your average. It may fluctuate a little bit less, may fluctuate a little bit more. Approximately, you should have a cardiac output of around 5 to 6 liters per minute. That's the total volume of blood pumped out of the heart in 1 minute of time. Your ejection fraction. Now, some of y'all have heard this because we've been talking about it in clinical. Your ejection fraction is the measure of ventricular efficiency. How well is that ventricle pumping blood out to the body? And we can measure the ejection fraction with a test known as an echocardiogram. And we'll talk about an echocardiogram when we get over to our diagnostic test in the second part of this chapter. This ejection fraction refers to how much blood within the left ventricle is ejected with each heartbeat. Normally, the value should be between 55 to 70%. So your normal ejection fraction should be around 55 to 70% of the blood that fills in that left ventricle should be pumped out of that left ventricle to the body. Now, there is a law of physics that we need to kind of address a little bit, and it is referred to as Stirling's law. Now, with Stirling's law, I gave you all a rubber band with your handouts that coincide with this chapter. Now, I want you to take your rubber band and kind of stretch it out a little bit, and then just kind of let it go. Like, put it around your thumb, use the pointer of your other hand to stretch it, and then slip it out. What happens to that rubber band? Okay, you should be seeing that as you stretch it and then release it, it bounces back, all right? And that's kind of what Stirling law is all about. As venous return increases, meaning as more blood flow comes to the heart, and your myocardium stretches, when it stretches, contraction is going to be more forceful, and there is going to be more blood pumped out with each heartbeat to an extent. Okay, so let's go back to your rubber band. I want you to hold it, and I want you to pull it just a little bit and kind of let it go, like you're shooting the rubber band across the room. Did it go very far? No, because it wasn't stretched very much. Now, I want you to put it on the tip of your finger, stretch it a lot, and then let it go. Did it fly halfway across the room? Yes, because it has more force behind it. It had more stretch that generated more force whenever it bounced back. And that is Stirling's law. As the blood comes into the heart, fills up your chambers, stretches that heart muscle out, whenever contraction occurs, that contraction is going to be more forceful. So more blood will be pumped out with each beat, with each contraction. All right, consider exercise. During exercise, your heart rate increases. With the increased heart rate comes increased volume that is pumped out. So cardiac output can increase up to 4 times that of a resting state during exercise. Remember, your cardiac output is stroke volume times heart rate. So when your heart rate goes up, you anticipate that your heart keeps up and there will be more cardiac output. All right, so Starling's law, play with your rubber band. The more you stretch, the more expansion causes a greater force of contraction, and hopefully that comes with more blood flow being pumped out with each heartbeat. Now, heart regulation. The heart generates its own impulse, but the nervous system can change the heart rate in response to environmental stimuli. The medulla of the brain contains your cardiac centers, and this figure that you see on your slide, it comes straight from your text in figure 21.4. Now again, your heart rate generates its own electrical impulse, but your nervous system and brain kind of oversee all of that. And we have to talk about your two different centers in that medulla of the brain, and the medulla towards the brainstem. The brainstem contains your vital functions of breathing, blood pressure, heart rate. You have two centers in the medulla of the brain. It is the acceleratory center as well as the inhibitory center. Your acceleratory center can be stimulated by exercise, can be stimulated by stress. Here is where your nervous system stimulates your sympathetic division. The sympathetic division increases heart rate and force of contractions. So you have the acceleratory side, which means to increase. That is affected by your sympathetic nervous system. Your inhibitory center, think about slowing it down, can be stimulated by a rise in blood pressure. Okay, think about that in terms of shock. When your blood pressure is low, we stimulate the sympathetic nervous system. But when your blood pressure raises up and gets back to normal, you kind of slow things back down. And the opposite of your sympathetic nervous system is your parasympathetic. So your parasympathetic division, impulses are slowed down via the vagus nerve. So your heart rate slows down as parasympathetic stimulation of your vagus nerve. All right, heart rate regulation. Heart rate generates its own electrical impulses. Remember, SA node fires at 60 to 100 beats per minute. That's why we get an average heart rate of 60 to 100. But your nervous system can affect that stimulation. Your acceleratory center, being your sympathetic nervous system, increases heart rate and force of contraction. Your inhibitory center can be stimulated by a rise in blood pressure, and your parasympathetic nervous system slows the heart rate down via the vagus nerve. That's why when you hear vagal stimulation, that means the heart rate slowed down. If it slows down too low, your patient passes out because they're not getting enough perfusion to the brain. Okay, so that is heart rate regulation. Hormones in the heart. Epinephrine. Epinephrine is a hormone that you have heard about. We've talked about it in neuro. It is a hormone, so you may remember it from endocrine. You should remember it from endocrine. And with that being said, I want you to send me the answer. You can email it to my school address, toakley@marion.k12.sc.us, or you can text me like you've been doing. Epinephrine is secreted by what gland? It is secreted in response to stressful situations, so it's associated with your sympathetic nervous system. And so it will cause a sympathomimetic response. So it mimics sympathetic nervous system. You're going to see an increase in heart rate, an increase in the force of contractions. Your coronary arteries are going to dilate because that's one of the vital organs, and blood flow is going to be diverted to that vital organ of the heart. Both this increase in heart rate, increase in force of contraction is going to increase cardiac output as well as increase systolic blood pressure. Now, another hormone that you will see can affect the heart is called aldosterone, and this also is a hormone that you learned about during endocrine. Aldosterone is secreted by the same gland as epinephrine, just different portion. So I want you to tell me what gland secretes epinephrine, which will also secrete aldosterone, but which portion of that gland secretes epinephrine versus which portion secretes aldosterone. Aldosterone is part of that salt, sugar, sex hormones, your glucocorticoids, your mineral corticoids that we talked about in endocrine. And aldosterone is important for cardiac function because it helps regulate blood sodium and potassium levels that are needed for electrical activity by the heart and by the myocardium. So sodium and potassium are very important electrolytes in terms of cardiac contraction and cardiac electrical impulse, which is the electrical impulse that causes the contraction. Aldosterone signals the body to reabsorb or hold on to sodium while it excretes potassium. So aldosterone may cause some degree of hypernatremia, and then we want to hold on to sodium because water follows sodium. And it excretes potassium, so you may see some hypokalemia as a result of aldosterone stimulation. Still talking about hormones that can affect the heart, our next one is atrial natriuretic peptide or atrial natriuretic hormone. All right, natriuretic, y'all. Natriuretic or natrium is the chemical name for sodium. So we tend to relate that to, okay, this affects sodium somehow. Atrial, reference in the upper chambers of the heart, and this is abbreviated usually ANP or ANH, depending on whether you call it a peptide or a hormone. This atrial natriuretic peptide is secreted by atria of the heart when there is an elevated blood pressure or there is increased volume that stretches your atrial walls. This hormone inhibits aldosterone, and so it helps to promote excretion of sodium, because if you think back to what we just said with aldosterone, aldosterone tends to hold on to sodium so it can hold on to water. Well, this atrial natriuretic peptide is because of excess volume that is stretching the atrial walls, and so it is released, telling the body to get rid of some sodium, so hopefully water will follow. So your results are going to be sodium is excreted, water follows the sodium, resulting in some water loss, which leads to a decreased volume, and hopefully that in turn will decrease the blood pressure and decrease any vascular congestion. So atrial natriuretic peptide. Now this sounds very similar to what you guys have been hearing in clinical and what you have on your lab sheet, being the BNP. B means beta natriuretic peptide. All right, atrial natriuretic peptide, the ANP, refers to the atria being stretched. The beta natriuretic peptide is basically going to function the same way in that it's going to promote that sodium excretion to get rid of some water loss, but it's because the ventricles are being stretched. Usually heart failure is related to ventricular compromise, and remember your BNP is the #1 lab associated with the evaluation of heart failure. BNP is also found in higher concentrations than ANP, so it tends to be easier to measure. Both could be a reflection of fluid volume excess as in the situation with heart failure, but it tends to be easier to measure the BNP. And the ANP comes from the atria. The BNP is released from stretching of your ventricles. A, atria. B comes after or below the A, so that will be your ventricles because they are the lower portions of the heart. Blood enters the atria before it flows to the ventricles. That's how you can kind of remember that. But both of them are released. ANP or BNP are released when the chambers or the heart muscle is stretched in response to increased congestion, increased volume, and the whole result of this ANP BNP is trying to tell in the body to get rid of sodium so water will follow, and hopefully that will decrease that excess fluid volume. The blood vessels are also a component of your cardiovascular system, and I've mentioned this before in that with your blood vessels you have arteries, you have veins, you have capillaries. Your arteries are going to be the larger vessels that have that we measure in terms of blood pressure. They are going to connect to your capillaries. Your capillaries are going to be the site of gas exchange where your carbon dioxide is traded off with your oxygen. And then your veins are going to be on the other side of the capillary bed. Your arteries are known to take blood away from the heart, arteries away, and they're known to carry oxygenated blood. The only exception to this rule is that blood flow through the heart when that deoxygenated blood leaves your right ventricle headed to the lungs via the pulmonary artery. That pulmonary artery is the only time an artery will carry deoxygenated blood. With your veins, they generally are thinner walled and they carry the deoxygenated or the dirty blood. These are the vessels that are responsible for returning blood flow to the heart. Again, they are responsible for carrying the deoxygenated blood. There is only one exception to that rule, and again it falls with circulation within the heart. When blood leaves your lungs after picking up oxygen for the exchange of carbon dioxide, it returns to the left side of the heart via your pulmonary veins, and that blood in the pulmonary veins is going to be good, clean, oxygenated blood. So that is the only time that a vein will carry oxygenated blood. Blood pressure. When we talk about blood pressure, that is the force against the walls of blood vessels, and it's measured in millimeters of mercury, specified as systolic over diastolic. Normal average systemic arterial pressure runs around 120 over 80 millimeters of mercury. When we talk about blood pressure, we often also have to mention a term called peripheral vascular resistance, or PVR. That is the state of slight arterial constriction that helps to maintain normal blood pressure. That PVR is used interchangeably with the term blood pressure. Anytime your PVR increases, that will increase your blood pressure. So anytime there's an effect on the peripheral vascular resistance, it will affect your blood pressure. Now, some other things that will affect blood pressure, things like your heart rate. If the heart rate increases, then your blood pressure is going to increase to a point. However, that's the key, is to a point. If the heart rate gets too fast, and that's when we look at terms of, or when we look at signs and symptoms of decreased cardiac output. Because if your heart rate is too fast, it does not allow time for your ventricles to completely fill up with blood before those ventricles are contracting to pump blood out of the heart, and that's going to lead to that decreased cardiac output. And cardiac output, remember, is the amount of blood flow that's coming out of that ventricle. So if there is a decreased amount of blood coming out of that left ventricle, then that ultimately is going to lead to a decrease in blood pressure. So although we can say if heart rate increases, then the blood pressure will increase, there is a cutoff on that, because there is instances when your heart rate is going too fast and it's not allowing for your ventricles to completely fill up with blood before we are pumping that amount of blood out, and that will decrease cardiac output, ultimately leading to a decrease in blood pressure. Contractions, force of contractions will also affect blood pressure. If contractions increase or the force of contraction increases, then blood pressure increases. If contraction is weaker due to maybe a decreased blood return to the heart, then your blood pressure will decrease. And because these contractions are weaker related to a decreased blood volume coming back to the heart, we also have to consider the next effector of blood pressure, which is that venous return. That venous return is how much blood is coming back from the body to come to the heart, to circulate to the lungs, to pick up oxygenation. So venous return affects blood pressure too, and several things can affect venous return. Things such as venous constriction, to decrease pulling in the legs, skeletal muscle pumping, to squeeze those deep veins of the legs, again helping to promote that return of volume to the heart. The diaphragm's downward pressure during inhalation, and venous valves that help prevent backflow of blood. If your valves are not functioning properly in the veins, then you will see pooling in the distal extremities, and that will lead to a decreased volume returning to the heart. Another effector of blood pressure is large artery elasticity. It helps to maintain normal pulse pressure, and that pulse pressure is the difference between systolic and diastolic pressures. That usual ratio is 3 to 2 to 1. So 3 tends to represent the arterial pressure, that's systolic pressure. 2 tends to reflect that diastolic pressure, and then the difference is going to be the 1. So that ratio that is maintained for normal pulse pressure is 3 to 1. And large artery elasticity, you cannot help but think about things like arteriosclerosis and atherosclerosis, where there is hardening of the arteries where they will not stretch, dilate appropriately, as well as that plaque buildup inside of the arterial walls. Again, kidneys tend to affect your blood pressure. When there is kidney blood flow that is decreased, that leads to kidney function declining, and when the kidney function declines, urinary output decreases. So that means the patient is holding on to extra water, extra volume, and that in turn will increase the blood pressure. Now, as we talk about kidneys, we cannot refrain from talking about that renin-angiotensin-aldosterone mechanism that you have already heard so much about. So again, with kidneys, they are the first organ to be compromised when there is a lack of circulation or a lack of blood flow or blood volume. When that lack of blood flow or blood volume occurs, the kidneys will be sacrificed, and when the kidneys don't get their fair share of blood flow, then their function will decline, and that function decline leads to decreased urinary output, with the patient holding on to volume, holding on to water, and that increase in volume leads to an increase in blood pressure. Okay, now I'm going to switch slides, and we're going to talk about the renin-angiotensin-aldosterone mechanism. With this RAA mechanism, renin-angiotensin-aldosterone mechanism, we go all the way back to shock when we talked about the compensatory mechanisms for trying to maintain tissue perfusion. We have gone through this renin-angiotensin-aldosterone mechanism several times in the past. Now we are going to go through it again, and it is outlined in your text in figure 21. I think it's 21.6, and I need you to know the steps of this renin-angiotensin-aldosterone mechanism. Okay, So we start off with the decreased blood pressure, hypotension. When there is hypotension, the first organ to be compromised is the kidneys. So your kidneys are going to realize, oh my word, I'm not getting what I'm supposed to be getting. And so they will try to save themselves. Just like the body is programmed to fix itself, the kidneys are part of that body. So when they don't get adequate blood flow, then they will release a substance called renin. Renin splits angiotensinogen from the liver into angiotensin 1. Angiotensin 1, with the help of ACE, angiotensin converting enzyme from the lungs, becomes angiotensin 2. Angiotensin 2 is a potent peripheral vasoconstrictor, and that vasoconstriction will in turn help blood pressure increase. Now, angiotensin 2 also signals the release of aldosterone. If you think back to what we've talked about earlier in this chapter, but also back to the endocrine chapter, aldosterone holds on to sodium. Well, what follows sodium? Water. And so as that sodium retention occurs, there is water retention, and that increases the blood volume. And when volume is increased, you get blood pressure increase. Okay, so the renin, angiotensin, aldosterone. Let's go through it one more time. There is decreased blood pressure, stimulating the kidneys to secrete renin. Renin splits angiotensinogen from the liver into angiotensin 1. Angiotensin 1 with ACE, angiotensin converting enzyme, from the lungs becomes angiotensin 2. And angiotensin 2 has two actions. Angiotensin 2 is a potent vasoconstrictor, so it will cause blood vessels across the body to vasoconstrict significantly, causing an increase in blood pressure. Angiotensin 2 also stimulates the release of aldosterone, causing sodium retention. That sodium retention causes water retention, increasing blood volume, causing an increase in blood pressure. Now again, you need to know these steps, and yes, you may have to write them out step by step. Don't forget the organ that secretes the substance. The kidneys secrete renin. Angiotensinogen comes from the liver. ACE, that angiotensin converting enzyme, comes from the lungs. All right, so don't forget your various organs that come into play here, along with those steps of this renin, angiotensin, aldosterone mechanism. Other hormones that can affect the blood pressure. We've talked about hormones in the heart. Now we're talking about the hormones that can specifically affect the blood pressure. And some of the first ones we see are norepinephrine and epinephrine. They are associated with your sympathetic nervous system, and they will cause vasoconstriction in the skin and viscera. And because they cause tachycardia and palpitations, which are that increased force of contraction, they will also increase cardiac output. Antidiuretic hormone, or ADH, secreted from your posterior pituitary gland, helps to conserve water and thus increases blood volume. Anytime you have an increase in volume, you normally will see an increase in blood pressure, just like the opposite will occur. If you see a decrease in blood volume, you normally see hypotension. And then finally, that atrial natriuretic peptide, ANP, releases sodium, or causes the release or excretion of sodium. Remember, water follows sodium, so the patient urinates out more extensively, decreasing blood volume and thus decreasing blood pressure. So your atrial natriuretic peptide tends to work kind of the opposite of what your ADH will work. ADH holds on to sodium, holds on to water, increases the blood pressure. ANP excretes sodium, excretes water, decreases blood pressure. Okay, now we need to look at your pathways of circulation, and this is where I want you to refer to the handout that I have given you. On one side of the handout you see pulmonary circulation, and on the other side of the handout you see systematic or systemic circulation. All right, let's start with pulmonary. Pulmonary and systemic are your two types of pathways of circulation. So basically we're looking at blood flow through the heart to the lungs. In systemic circulation, we're looking at blood flow through the heart to the body. All right, so let's start with your pulmonary circulation on your handout. With your pulmonary circulation, this begins at the right ventricle. So we're inside of the heart, blood has returned via the vena cavas, went through the right atrium, through the tricuspid valve. We are sitting at the right ventricle, and this pulmonary circulation tells us that we're on the way to the lungs. So we begin at the right ventricle, we travel through the pulmonic artery. After we pass through the pulmonic valve, so right ventricle, pulmonic valve, to the pulmonary artery. And from the pulmonary artery, blood flows to the left lung, to the right lung. Those arteries flow to the pulmonary capillaries, where the exchange of oxygen and carbon dioxide occurs, to flow out to the pulmonary vein. And the pulmonary vein carries this oxygenated blood back to the left atrium. So pulmonary circulation, leaving the heart, heading to the lungs, doing the gas exchange, then returning back to the heart on the left side. So we start at the right ventricle. Blood passes through the pulmonary valve, pulmonic valve, into the pulmonary artery, travels to the left and right lung, to the capillary bed, where the exchange of oxygen and carbon dioxide occurs. Oxygenated blood now travels via the pulmonary veins back to the heart to the left atrium. Okay, your systematic or systemic circulation. This is where we leave the heart and head out to the body. So this begins in the left ventricle. So from the left ventricle, blood passes through the aortic valve into the aorta, travels via the aorta, branching off into the arteries, then the capillaries. Gas exchange occurs. This is where we drop off oxygen and pick up the carbon dioxide, so blood is now deoxygenated, and it will be entering into your veins, which grow bigger and enter into your inferior superior vena cava to return back to the heart at the site of the right atrium. Okay, so systemic circulation begins in the left ventricle, flows through the aortic valve into the aorta. From the aorta, we branch off into the coronary arteries and the arteries of the body, flow to the tissues, into the capillary bed where oxygen is dropped off, carbon dioxide is picked up. We are now looking at deoxygenated blood that enter into your veins. Those veins get bigger to the point of the inferior superior vena cava and enter the heart at the right atrium. So we learned about blood flow inside of the heart, and these pathways of circulation are it talks about blood leaving the heart. Pulmonary circulation talks about going to the lungs. Systematic or systemic circulation talks about blood going to the body from the left ventricle. Okay, pulmonary circulation, blood starts out deoxygenated and becomes oxygenated. Systemic circulation, blood starts out oxygenated and returns deoxygenated. Now that we've talked about the normal anatomy and physiology of your cardiovascular system, I want to move over to discuss the aging effects on the cardiovascular system. We are discussing in MedSurg primarily the adult client, and we tend to see cardiovascular disease evolve more so as we get older. And so we definitely need to consider what aging does to our cardiovascular system. Aging of the blood vessels begins in childhood, and the effects are not really apparent or seen until later in life. So basically, everything that we do from the time we are born up through the time of our death will affect our cardiovascular system. That's very kind of eye-opening when you look at it in terms of being a parent and what we feed our children on a daily basis. I personally, my life is beginning to slow down just a little bit because my kids can drive them around, but me trying to keep up with them and be a part of their extracurricular activities keeps me on the go. But I remember when we first got into our sports and playing baseball and basketball and so forth, it consumed a lot of our time, and we had very odd hours for eating, and those odd and late hours contributed to us eating a lot of fast food. So I, as a parent, what I was feeding my children could very much affect their cardiovascular system. I mean, think about it. If you eat a cheeseburger every day, how much fat accumulation is occurring in your arteries all over the body, which in turn you may not see as a problem right now, but when you're 50, 60, 70, 80 is when we begin to see the manifestations of how well we took care of our body early on in life. So that's what we're saying. Aging of the blood vessels begins from the time we're born, but we may not see the effects until much, much later in life when we're looking at age 50 and above. Some of those issues that we will see. As you look on the left-hand side of your slide, you have this very same diagram in your textbook because it is quintessential and very much common to see these circles, squares, and rectangles associated with aging of any body system. So we're looking at figure 21.7 in the text. And if you look at those various circles, you can see the effects that are going to occur and what they may lead to. So you're looking at conduction cells being less effective. So your patient's at risk for dysrhythmias. You're looking at atherosclerosis, that narrowing in the blood vessel lumens, the rough surfaces that are going to attract platelets and cause the body to be more at risk for clot formation. Not to mention, because the vessel lumen is narrowed, that is going to lead to decreased blood flow to the heart and to some of the other organs of the body. Resting blood pressure increases. So your left ventricle, being that workhorse of the heart that has to overcome the body blood pressure, is going to have to work harder. So you will see a higher instance of left-sided heart failure because that resting blood pressure increases, and because there is that possible occlusion in the arteries. There may be a decrease in perfusion to the brain, leading to a stroke. There is a decrease in heart rate that can contribute to the older patient feeling very fatigued and tired all the time. And you can see vein valves being incompetent, leading to pooling of blood in the distal extremities, called venous stasis. And that venous stasis could lead to venous stasis ulcers. All right, on the right-hand side of your slide, you see the various problems that come about. And your atherosclerosis is that depositing of lipids or fats into the arterial walls over time, which again leads to that narrowed lumen, that narrowed opening that decreases blood flow and causes rough surfaces that stimulate intravascular clot formation. Arteriosclerosis is where those arterial walls become stiff and lose their elasticity. So you will see arterial elasticity affected, and that can be one of the things that affects our blood pressure. If it affects our blood pressure, it affects the workload of the heart, specifically your left ventricle. Average resting blood pressure tends to increase with age, possibly leading to strokes or left-sided heart failure. talked about the veins weakening and stretching, making your valves incompetent, leading to venous stasis and venous stasis ulcers. Dysrhythmias occur due to a less efficient cardiac conduction pathway, and your heart muscle becomes a little less efficient. There's going to be potentially wearing out, potential stiffening of that heart muscle, which is going to contribute to a decrease in cardiac output. All right, so these are aging and your cardiovascular system. And that kind of brings us up to about the halfway point, where the next session will start on nursing assessment. But before we leave, let's do some review questions. Review question number 1. What effect does epinephrine have on the body? And you need to select all that apply. Number 1, increases heart rate. Number 2, slows cardiac conduction. Number 3, strengthens the force of contraction. Number 4, increases cardiac output. Number 5, increases systolic blood pressure, the effects of epinephrine on the heart. And consider what you know about epinephrine. You've learned it from shock. You know that it's part of the sympathetic nervous system. So I'm going to give you a few seconds to think on your answers. And your answers are: epinephrine increases heart rate. It strengthens the force of contraction. That's why we tend to see palpitations secondary to epinephrine release. Increases cardiac output. Well, if I increase the force of contraction and I increase the heart rate, that will increase the cardiac output. Think about the stroke volume times the heart rate equals cardiac output. And it increases systolic blood pressure because it causes vasoconstriction in your peripheral arteries, be in your skin, and some organs. Review question number 2. The nurse plans for an older adult based on what effects that occur when aging in the cardiovascular system. Select all that apply. So number 1, arteriosclerosis. Number 2, blood pressure decreases. Number 3, your vein valves are more competent. Number 4, your heart muscle is less efficient. Number 5, arrhythmias are common. So we think back to those squares, circles, and rectangles that we just looked at in the last slide of the content. What are associated with the effects of aging in the cardiovascular system? Give you a few seconds. And your answers are: arteriosclerosis, that's stiffening of the arteries. Number 4, heart muscle becomes less efficient. And number 5, your arrhythmias become common because of that decreased effectiveness of your cardiac conduction system, that electrical aspect of the heart. Okay, again, this marks the first part of Chapter 21, and it is the review of the normal anatomy and physiology of the cardiovascular system. I know this does not necessarily take the full content time that you are allotted for this session of class, but there's quite a few things that you need to master. You need to go back and kind of learn, memorize that blood flow through the heart. You need to memorize and be able to write out the renin, angiotensin, aldosterone mechanism, and that's going to take some practice. So I've purposely kind of tried to take my time and allow you more time to work through this PowerPoint, but then also go back to your text, go back to practicing, writing it out, see if you can remember certain things. I mentioned the blood flow through the heart. I mentioned the renin, angiotensin, aldosterone mechanism, and then there's that sequence of cardiac conduction, the SA node to the AV node to the bundle of His to the right and left bundle branches to the Purkinje fibers. So there's a lot for you to kind of go back and recap and remember from phase 1, or that is presented new here in MedSurg in Chapter 21. If you have any questions after doing this PowerPoint, this lecture, please reach out to me. We will grow in Chapter 21, moving to the assessment along with the diagnostic test and the therapeutic interventions.